So I would like to go on. Thanks for sharing those valuable pointers. We know how important is the registry. Now, any patient with any disease would want to live a normal life. Dr. Anu, can you tell us about the patients with MS life? They want to live a normal life. How about the approach of early hit, hardened management of MS? If you can throw light on that, Dr. Anu.
That's very important question. So, as we've heard from Dr. Padma, Dr. Iyer, Dr. Khurana, and Mohan, that this is a disease which affects young people, at the prime of their life, where a new phase of their life is starting, new job, new family, children. So, we would want as doctors, as a society, to see that they can lead as normal a life as possible. And think we should, as a family, a society, and as a medical fraternity and MSSI, aim to fulfill that dream. And I think if we can surmount the barriers of early diagnosis, we luckily now in 2024 we have drugs to help us achieve that. So the idea is to diagnose these people, provide the correct therapy, provide the multidisciplinary care, focus on a patient, see that they lead a life, and also to give them confidence that that life is possible. And I think in this respect, Google would be back-footed, because what has happened with MS and the way the treatment has evolved from, say, no treatment to interferons to very effective oral drugs, the quality of life of patients has drastically improved if we've been able to diagnose them in time. So if you go on Google, the data which is available about disability stories may not actually hold true in the current context. Having said that, this is an evolving field. We have heard that MS is a very heterogeneous disease, and one treatment doesn't fit all. So, while these treatments are being enforced, and the current approach is that you have a patient with MS, you see how many relapses they are getting in a year, or new symptoms, and you also do periodic MRIs and see that how many relapses they're getting, because sometimes patients do develop changes on the MRI without any symptoms, and given together, if you add the clinical relapses and the MRI relapses, say in 1 year, if that is high, you escalate therapy, and you go from step 1 to step 2 to step 3 to step 4. The idea being that the higher the therapies at a higher step are definitely more effective, but you have to be vigilant about their adverse effects, which may be more severe or more frequent. But overall, the risk benefit ratio is in favor of the patient, and the patients would benefit from the therapy in controlling multiple sclerosis related inflammation and degeneration. But we also know from parallel studies that this may not be a true assessment on the way MS is progressing, because the patient may not get obvious symptoms. The routine MRIs, which we do, may not show new lesions, but if we do finer radiological tests, we may detect lesions which were not seen. And if we measure patient disability very finely, we see that they are getting disabled over time, even though they have not had discrete relapses. And this is what has prompted the concept of what we call as HIT, as it high intensity therapy, where we hit and give a high intensity immunosuppressive agents right in the beginning of the disease to basically kill all immunosuppression. It's like using fire brigade. Just kill all the inflammation and then take it slow as per the patient's need. So, of course, the flip side being that we are exposing patients to potentially more side effects, but maybe these are offset by newer drugs which have been marketed and which are still under trial basis, where the side effect profile would be even better. And luckily for us, we have these high intensity therapies available in India, like natalizumab, acilituzumab, or silizumab, rituximab, we talked about. Even bone marrow transplantation is considered in certain instances. So there's no dearth of therapy. The concept is, do we do use these therapy or hit therapy in disease course where the disease is escalating and not responding to the first or second line of treatment, or do we hit hard right in the beginning of the disease? Now, if we are going to hit hard right in the beginning of the disease, it would be good to have certain biomarkers which are yet being studied, to see which are the patients who are not going to do well with the first two steps and we directly go to the third step. But this is a very interesting concept, and we are looking closely as a medical fraternity into this. The offset, I think, is also the cost. As we go up to more intensive therapies, the cost of treatment greatly rises, and that is where, classifying MS as an orphan disease and the work being done by the MSSI and the patient advocacy at multiple levels, say at national and international levels, does help, because these the drug costs are prohibitive, and they, if we make concentrated efforts, they can be reduced if the patient base using the drug increases, and if we increase the outreach to the patient, that itself helps reduce the cost of the drugs. But I think we are looking at hit therapy very closely.
Adding to it, thanks a lot, Dr. Anu, for those pointers. Adding to it, Dr. Dheeraj, you have anything more to cover on how about the approach of hit early, hit hard in management of MS?
Yes, going early is basically early intensive therapy, as we call it. I think I'm a very strong proponent of early intensive therapy. Reason being, for whatever the discussion preceding this, we've been talking of how important it was to diagnose early, and why it's important to diagnose early is because the disease is very severe, mostly severe in the first few years. Now we do have ample evidence and also ways to detect which disease or which MS is going to behave more aggressively, what we call as aggressive MS, or we call as highly active MS. So thankfully, over the years, data which has accumulated, we can find out, for example, a patient who's had more than 2 attacks in 1 year, or even more than one attack in 1 year. We consider that as a disease towards going towards aggressive, or who have symptoms relatable to the spinal cord more and who do not recover completely. These are some of the examples. So these are highly active disease, and even right after the first attack, we can predict that this disease is not going to behave in a mild fashion. And with these are the cases we should be very, very, I would say, surely treat them with high early intensive therapy, or hit them hard with a therapy. And thankfully, we have all kinds of treatments available. So if cost is a constraint, I would not shy away from saying rituximab is one of the best therapies, and all my colleagues, I think they've been using a lot of rituximab across the country. In fact, to name quite a few centers across the country, in fact, because that is easily available, low cost, patients tolerate it well. Every 6 months you have a therapy. But if we really need to offer all the latest treatments, even those are available currently in our country, like Ocrevus, natalizumab, Dr. was talking, and those are excellent drugs. In fact, I usually give the believe in offering all these medications and then discussing it with the patient on a shared decision-making pattern, so that people, they know what is available, and then they take a right decision based upon their own personal scenarios. And that is the reason ideally, and there is ample registry based as well as trial based data which tells us that early intensive therapy is definitely better, because it reduces the chance of a patient going into long term disability maybe 10 years down the line, versus an escalation uh, uh, paradigm which was actually practiced many years back, that you go with first line platform therapies, then you go on to a high end. We are currently seeing a paradigm shift, and more patients are actually identified as candidates to go for early intensive therapy. And why we should do that? Because we are not harming them. There are two things that we need to see in a treatment: high efficacy and safety. So if we have a treatment which is highly efficacious and safe, I see no harm in giving such therapies versus, there are conditions where you have therapies which are highly effective, but also have serious side effects. There are drugs in rheumatology, in cancer, cancer is also same. I'm not saying this is the same thing, but we hit hard, but you have a lot of side effects. Here, we hit hard, but side effects are minimal and are manageable. So that's the balance that we create, and we should, I think, go ahead with that.
Thanks a lot, Dr. Dheeraj. Now, again, going back to Mr. Sandeep, we would like to learn the importance of early diagnosis from the doctor's perspective. We have already heard. So, from the collaborative perspective, if you can give us the importance of early diagnosis and early initiation of accurate treatment, and most importantly, challenges in getting reimbursement for treatment in India. That must be a challenge. So, patient advocacy perspective is needed here. Over to you, Mr. Sandeep.
Thank you. Thank you, Pratibha. As far as early diagnosis is concerned, definitely it is important to have early diagnosis. And as all of our doctor panelists have suggested, that early treatment is the absolute necessary. So now early treatment, all this early treatment definitely involves a lot of money. So that is where we would say advocacy comes into picture completely. Most important part of advocacy is insurance. See, if it is insurance is there, then it will be possible insurance which is covering properly. That is very crucial because now insurance policy is specifically designed to cover 21 disabilities uh, in which uh, multiple sclerosis is also included. 21 disabilities under RPWD Act. So all the insurance companies have designed the policy for this disability. However, there are major lacunas as the policy is not affordable for premium wise, and the issue is whether everything, the DMT, basically they are being administered like a chemotherapy drug in outpatient department, whether claims will be settled properly. So this is a gray area which we want to convert completely into uh, confirmed statement from insurance company that this will be covered. DMT's treatment will be covered as an outpatient treatment, just like chemotherapy. And it has to come up. So we are doing a lot of advocacy for that, and also getting insurance policies for people. Then another area is classifying multiple sclerosis as a rare disease. The moment it is classified as rare disease, as Dr. Anu Aggarwal also has specifically mentioned, that the moment it is classified as rare disease, we are getting benefit for research aid also and the treatment aid from the government. So that is where we are looking at support from the government, and we always look forward to it. Thank you.
Thanks a lot, Mr. Sandeep, for your thoughts. I know there are a lot of questions. We have done. We are running out of time. I think the MSSI has given an email ID. It's hoadmnmssi@gmail.com. So whoever has any questions, please write to them. They would be getting on to the expert doctors, and maybe they will get the responses which is needed. So
We will definitely do that.
yeah.
Promise,
So
Pratibha.
Thank you.
there are a lot of important questions on the drugs, on the scan. I think these needs to be addressed, and the doctors would definitely do it. So with that, we have come to an end of this enlightening session. Thanks a lot for the panelists from ET Health World side.